The Appropriations Subcommittee on Labor, Health and Human Services, Education, and Related Agencies will come to order. And I will start by recognizing myself for an opening statement, followed by my ranking member, Senator Capito. Good morning. I want to welcome everyone to the Senate Appropriations Subcommittee on Labor, Health and Human Services, Education, and Related Agencies' first hearing on the Biden administration's fiscal year 2025 budget request. We completed our work on fiscal year 2024 appropriations less than 4 weeks ago. The final fiscal year 2024 appropriations bill, which was very much a compromise, but I was proud of that bill and the bipartisan work that went into it. At the same time, Mr. Secretary, you received your fiscal year 2024 appropriations more than halfway through the fiscal year. That makes your job harder, and it's also a disservice to Wisconsinites, West Virginians, and communities all across the country that rely on funding and programs the Department of Health and Human Services administers. We have to do better. And to be clear, last year, the Senate did its job under the leadership of Chair Murray and Vice Chair Collins. We reported overwhelmingly bipartisan bills out of committee last summer. I look forward to continuing to work hand in hand with my ranking member, Senator Capito, again this year. We just need cooperation from our colleagues on the other side of the Capitol. And a key part of that is agreeing to adequate top lines that allow us to address important and bipartisan priorities. Kicking off our fiscal year 2025 process today, I'm happy to welcome Secretary Becerra for our hearing on the administration's fiscal year 2025 budget request for the Department of Health and Human Services. Secretary Becerra, this budget highlights the need for continued investments among a wide range of bipartisan priorities that speaks to the breadth of activities you oversee as the Secretary of Health and Human Services. Working within the budget constraints of the Fiscal Responsibility Act, I'm pleased to see that this year's budget request meets families' most pressing needs, like lowering the costs of health care, tackling the fentanyl and opioid crisis, expanding access to affordable child care, and helping connect people with the mental health care that they need. This budget request includes increased funding to address our abysmal maternal health and mortality outcomes, including expanding the maternal health workforce and improving access to care in rural and underserved communities. This is Black Maternal Health Week, which should be a glaring reminder that every pregnancy-related death is tragic, and Black women are 3 times more likely to die from pregnancy-related causes than white women. This budget will help improve maternal and child health outcomes, including addressing racial disparities. This budget recognizes the need for continued investments in child care and early learning programs. Sustained annual increases like the $1 billion increase for child care and Head Start in the fiscal year 24 labor HHS bill are critical, but more needs to be done. In Wisconsin, some families are now spending more than 35% of their income on child care. Running a family with 2 young children, more than $25,000 per year. That is more than college tuition for many families. The steep cost not only impacts families, but also businesses and our economy that feel the ripple effect when parents can't find childcare. This request ensures that we are better prepared for and able to rapidly respond to emerging biological threats, including supporting the domestic manufacturing of medical countermeasures and other critical resources in the public health supply chain. It also strengthens our core public health infrastructure, workforce, and data modernization programs nationwide to improve readiness for the next public health crisis. I am pleased to see the support for biomedical research and innovation to develop better diagnostics, improve treatments, and precision care for patients, including targeted investments for research on women's health and in support of the goal to cut the cancer death rate by at least 50% over the next 25 years. I'm also happy to see investments to improve access to reproductive health care, including expanding the Title X family planning program, which helps so many patients, particularly women of color, get birth control, cancer screenings, STD screenings, and other essential health care. I believe that we need to do more in these areas to truly meet the need. But, Mr. Secretary, I appreciate this budget request prioritizing funding under the tight budget constraints and look forward to working with you on them. To that end, Mr. Secretary, I want to hear more about how HHS is working within its agency to address our nation's mental health and substance use disorder crises. Tragically, overdose deaths remain stubbornly high and continue to break records year after year. In 2022, nearly 108,000 Americans died of an overdose. In my state of Wisconsin, there were 1,828 drug overdose deaths in 2022, surpassing the record set in 2021. Of these deaths, 1,464 involved opioids. I know my colleagues are seeing similar grim statistics in their states. Of particular interest, I will want to know how the administration is specifically addressing poisonings due to fentanyl. This drug is wreaking havoc across the country, and we must partner to take an all-of-government approach to prevent it from coming into our communities, reduce use and misuse, and make accessible treatment programs and overdose reversal medications available. Finally, Mr. Secretary, women's health and reproductive rights are under attack in this country. Draconian laws are being put in place that deny Americans their rights to control their bodies, their families, and their futures, and that put women's health and well-being at risk. Just last week, we saw Arizona reinstate an 1800s-era abortion ban, not dissimilar to my home state of Wisconsin's 1849-era criminal abortion ban that had devastating consequences. Everyone deserves the freedom to make their own health care decisions without interference from politicians and judges. I want to hear more about what HHS is doing to protect women's health and ensure women can access the reproductive health care that they need. I look forward to your testimony and appreciate your being here today. In a moment, I'll turn it over to Ranking Member Capito for her opening remarks. Following Senator Capito's opening statement, we will hear from you, Secretary Becerra, and after that, senators will each have 5 minutes for their rounds of questions. Senator Capito.
Thank you. Thank you, Chair Baldwin. Thank you, Secretary Becerra, for coming, and thank you for sharing our thoughts a bit yesterday over the phone. I appreciate that. As Chair Baldwin noted, last year, the Senate Appropriations Committee marked up all 12 bills for the first time in 5 years. I hope we can do it again, and this budget hearing is necessary to be a first step in that process. And so I look forward to hearing more about HHS budget proposals and the priorities for fiscal year 2025. I want to thank Chair Baldwin for working together, bipartisan. The success of our process depends on finding common ground, as we did for fiscal year 2024, albeit 6 months late. We finally reached that. This budget proposes more realistic funding levels in some areas to align with that Bipartisan Fiscal Responsibility Act, and I commend you for that. However, unfortunately, the budget also continues proposals for new partisan mandatory programs that would spend too much money that we, in this day and age, we just do not have. Instead of focusing our common goals to improve the health of Americans, the budget yet wades into polarizing issues, such as repealing the Hyde Amendment, increasing funding for Title IX, family planning, and gun violence research, and funding new climate change initiatives. These are all sort of recycled budget policies that the Congress has rejected over the last 3 years. Also, I want to note my disappointment, this is a personal thing for me, that the budget did not prioritize any new resources specifically for Alzheimer's research. I acknowledge we are facing very difficult spending climate, that we can hope we can focus on bipartisan areas of need, including a continued focus on biomedical research, supporting rural health care, growing our health workforce, it's a huge problem across the country, and continuing to combat the devastating effects of substance abuse, as Chair Baldwin noted. I was pleased to see a focus on biomedical research related to the cancer moonshot across HHS agencies, including NIH and CDC. West Virginia, my home state, continues to rank above the national average in both new cancer diagnosis and deaths. Substance abuse challenges also continue to be a real problem facing the country, but particularly my state. We have some of the highest statistics here. Concerning to me, too, is a proposed $10 million for a new discretionary program for funding harm reduction grants. This is the Partisan American Rescue Plan program that famously attempted to fund crack pipes with taxpayer dollars, as my colleagues may recall, in the name of harm reduction. You did walk away from that ill-conceived policy. You walked it back, and I continue to have some serious concerns, and I would encourage a greater focus on primary prevention. Secretary Becerra, this is your fourth budget hearing before this subcommittee, so it should not be a surprise to you that rural health care is a priority for this body. I was a bit disappointed that the budget lacked new resources for rural health programs. In fact, it is $12 million below the recently enacted funding level. CDC data shows that rural Americans are more likely to suffer from higher rates of diabetes, are more likely to die from cancer, heart disease, and stroke than urban Americans. This is unfortunately true in my home state, which also leads the nation in rates of diabetes and heart disease. Improving rural health outcomes goes hand in hand with investing in the healthcare workforce. Your budget proposes timely investments, $63 million above fiscal year 2024 across behavioral health, nursing, and other health profession workforce training, so thank you for that. The mental health and behavioral health crisis highlights the importance of trained professionals in every healthcare sector working to meet the physical and mental health needs of Americans. Workforce shortages and rural health challenges should push all of us to think differently about how and where care is delivered. Telehealth should be a part of the equation. We learned that during COVID, and we've seen that used quite effectively. Yet the budget proposes an effective cut of $4 million to the Office of Advancement of Telehealth. The healthcare landscape is complex and ever-changing. I hope we hear from you today about these challenges and the other emerging challenges. Our jobs will be difficult again for 2025, given the economic realities that face our nation. Just as we did for fiscal year 2024, it is my hope that we will come together in a responsible way to find areas of efficiencies and focus on the many areas of agreement I have just discussed. Thank you, Secretary Becerra, for coming, and I look forward to your testimony.
Thank you, Senator Capito. Our witness today is Xavier Becerra, the Secretary of the Department of Health and Human Services. Secretary Becerra, thank you for joining us today. You will have 5 minutes for your opening remarks, and you may begin.
Chair Baldwin, Ranking Member Capito, and members of the subcommittee, thank you for inviting me to testify on the 2025 budget. When President Biden took office, I think it's important to note, back in January 2021, COVID was ravaging our families and our economy, and thousands of Americans were dying every day. Thousands of Americans were dying every day. About 4,000 died the day that President Biden took office. In January 2021, the number of Americans with health insurance was, like our jobs and the economy, down and on the canvas. Prescription drug prices were skyrocketing, with patients and their pocketbooks at the mercy of Big Pharma and its profits. We changed that. Today, 3 years later, nearly 700 million shots of COVID vaccines have gone into the arms of Americans. COVID is still around, but we can now manage it like the flu. Today, more than 300 million Americans, a record number, can go to the doctor or hospital and not go bankrupt because they have their own health insurance. More than 21 million of those Americans count on the Affordable Care Act marketplace for their insurance. That's another record. Today, while Big Pharma is still big, The president's new prescription drug law has brought down the price of insulin to $35 per month for Americans on Medicare. And as we speak, we are negotiating with drug companies to lower the price of even more prescription drugs, even as they sue us to stop us. The president's budget doubles down on the investments that made the comeback of our jobs, our economy, and our health possible. It doesn't just protect Medicare. This budget strengthens it beyond Medicare's lifetime and beyond our lifetime. This budget lays out a vision for a nation that invests in its most vulnerable. It fosters innovation, and it protects every American's access to the care that she needs. Perhaps most importantly, it continues our shift from a health system that treats illness to one that sustains wellness. All told, the FY2025 budget proposes more than $130 billion in discretionary and about $1.7 trillion in mandatory funding to advance our mission and invest in key priorities. Let me share a few of those highlights. The budget provides Medicaid-like coverage to low-income individuals in the outlier states that have not expanded Medicaid under the Affordable Care Act. When that happens, another 1.5 million of our fellow Americans will have health care coverage and the peace of mind that comes with it. This budget builds on the largest investment in behavioral health in a generation. It bolsters the 988 Suicide and Crisis Lifeline. It gives young people support at home and at school. The president's investments in behavioral health workforce would add 12,000 new psychiatrists, psychologists, clinical social workers, marriage and family therapists, counselors, and peer support specialists at a time when their services are desperately needed. Across HHS, the budget tackles a maternal health crisis by improving access to pre- and postnatal care, supporting emergency care services, and expanding maternal care in rural and underserved communities. We are also making child care more affordable for working families and more available where families live and work. This budget would provide increased wages for early childhood education workers. It would fund more than 750,000 slots for children in Head Start, and it provides universal preschool for our nation's 4 million 4-year-old children, and eventually would include our 3-year-olds as well. Our budget grows and strengthens our cybersecurity initiatives to ensure patient safety and privacy, and to keep our hospitals and providers, especially smaller ones and those in rural communities, running and secure. Finally, this administration has made tremendous strides in preparedness capabilities since the pandemic, and we keep building. This budget invests in countermeasures to combat antimicrobial-resistant drugs. It expands our monitoring of supply chains, and it integrates 200 data sources across federal, state, and local governments to improve information sharing. We can't reduce the health and well-being of Americans to a line on a budget spreadsheet, but we can transform the numbers on the balance sheet into real investments and services that sustain health and promote wellness for all Americans. With that, I thank you for this opportunity, and I look forward to your questions.
Thank you, Mr. Secretary. We're now going to begin our questions, and I'll start by recognizing myself. Secretary Becerra, our communities continue to struggle with the opioid crisis. I cited the statistics in my opening statement, but as a reminder, in 2022, 108,000 Americans died from a drug overdose, a record high. We've seen the opioid epidemic transform over the years. When I first was elected to the Senate, it was primarily an epidemic of prescribed opioids. Then we saw some shift to use of heroin. But now with the emergence of synthetic opioids like fentanyl, we are seeing an increase in deaths among individuals, particularly youth, who don't even know that they're taking fentanyl. With fentanyl, one pill can kill. How does the HHS budget address the devastation that we're seeing from opioid-related deaths in our communities?
Madam Chair, perhaps the most important thing is that we recognize, as you just mentioned, that it's a shifting landscape. And so the some $9 billion that the president's budget has to address drug overdose and the opioid addiction are really targeted on things like fentanyl, on trying to make sure that we give states the capacity to help their young populations avoid overdose. And it makes sure that we're providing the harm reduction to make sure that people don't accidentally kill themselves when they think they're doing something that is recreational. And so of the $9 billion, it should not surprise you that more than $1.5 billion is going to state opioid resource grants that will help states decide how they can best tackle the opioid crisis, especially among children. SAMHSA, our agency that administers most of our substance use and mental health programs, is going to receive about $4.5 billion of the $9 billion because they're the ones that work closely with state mental health programs throughout the country. And so it is letting the states have the flexibility and the resources to tackle this crisis.
I want to dig a little bit deeper here because, as I mentioned, many times teens will take a pill that they got from a friend or got online, unaware that it's laced with fentanyl. I've heard from so many parents in the state of Wisconsin who have lost a child to fentanyl poisoning. The budget proposes substantial funding for treatment programs, which is certainly incredibly important for tackling this crisis. But how is HHS working to prevent young adults from using, and children, from using drugs and making these deadly mistakes in the first place?
Madam Chair, we did something at the federal level that had not been done before. We stopped relying on stigma to drive our federal policy. So today, we actually support programs that offer fentanyl strips to individuals so they can find out if the drug they might be taking is laced with fentanyl. That way, they don't kill themselves. We also made naloxone far more available. So today, you can have access to naloxone in public places so that if you see someone who's overdosed, there's a great chance that you might save their life by administering naloxone for them. And so we're also trying to make sure that local communities understand what they can do to make that naloxone more available. So whether it is naloxone, fentanyl strips, clean syringes, we're now using the evidence-based programs that have shown success to drive our policies.
Thank you. I want to shift in 2018, I worked to pass legislation requiring HRSA to identify areas with critical shortages of maternity health care professionals so that we would have evidence to support increased investments in areas where women and families need providers the most. Unfortunately, the number of maternity care deserts nationwide continues to increase, and over 2 million women live in a county without a hospital, birth center, or obstetrics provider. The decision overturning Roe has made this problem worse, as states with abortion bans have seen a drop in applicants for obstetrics and gynecology residencies. Given our nation's unacceptably high rates of maternal mortality, we must do everything we can to target investment to increase access to care and support the maternal health care workforce. Secretary Becerra, what is HHS doing to build the workforce pipeline and better support our maternal care professionals?
Madam Chair, there are about $8 billion that are dedicated in this budget to trying to address maternal health. Much of it is focused specifically, about $400 million is focused specifically on trying to tackle the maternal mortality and morbidity rates that we see in some of our communities, especially the Black and Native American communities. We're trying to make sure that we get to women before there's any chance that they would have complications in their pregnancy. And as you know, as a result of our efforts on Medicaid and your support, we now are able to offer a woman and her baby not just 60 days of maternal health and child care after delivery, not just 60 days, but 365 days of care for mom and baby so they can make sure they're going to start with a fruitful life.
Thank you. Senator Capito.
Thank you. Yes, Secretary Becerra, I want to talk about rural health because I mentioned in my opening statement a $12 million, it appears as though it's $12 million lower. I understand that our bill funded it at 364.6 million, which is rural outreach, rural hospital flexibility, and other things. The request is for 352, which is lower, 12.2 lower than what we actually funded this for. I understand also that the budget release and then the timing of the actual passing of the budget were almost at the exact same time. Might not have been ideal for you. What would you say about that? Healthcare delivery systems in rural America are still very difficult and underfunded. We have the lowest life expectancies in rural America. What's your response to that?
Senator, you actually touched on probably the most important aspect of my answer, and that is that our budget was being framed at a time when we had no idea what the 2024 budget would look like, and because of the constraints on where we could go, we had to make sure we tried to be consistent with what might come out. So we are more than willing to work with you on the kinds of investments we would make in healthcare generally, but more specifically with regard to rural health. You will find that there are specific investments in rural health, especially in the area of substance use disorders, in trying to keep hospitals afloat, that we can work on to build on, because I think you're right. There's no doubt that it's tougher if you're in a rural community to find a healthcare facility near you. And so we'll do everything we can to try to keep not just them sustained, but also to have them thrive.
Well, we'll work on that and understanding the circumstances of when your budget came out.
Yeah.
I did have a lot of questions on drug abuse and SAMHSA, prevention and harm reduction. Here's the discouraging thing. These statistics are not coming down. I mean, the overdose statistics, I heard on the radio the other day that the statistics in DC alone were up, I don't know, 20, 30% deaths resulting from overdose. I don't think we have the statistics quite yet for this past year. We've got a flow of fentanyl coming up through the southern border. We got to do better here. I mean, we are losing a generation. And I understand in your last answer some of the areas, fentanyl strips and naloxone, but that's still just treating somebody who's already in heavy addiction. I mean, I think the prevention aspects of it have not gotten to the younger children as much as they should. We got to start kindergarten. What's your response to that?
With you, completely with you on that. Here's the difficulty. As you know, at the federal level, the Department of Health and Human Services, we don't administer these programs. We work with the states. The states are the ones that have control over healthcare and this aspect of healthcare. What we do is essentially provide them with more resources, or we give them some support and flexibility in doing what they can with the dollars that we give them. We are more than willing to work with the states to increase their capacities. They need more capacity.
What states are doing it? I mean, I'm sure you're looking at what the innovative programs of a state that might be able to be shared nationally. I'm sure that's best practices that you're pursuing here on the prevention side.
Oregon, as you know, had an issue with increasing drug use. And what they have done, when I've been to visit, I've seen how they are incorporating young people into their programs to try to get them to become essentially peer support, so that peer-to-peer kids are hearing from someone who can help them out. Obviously getting the adult and professional help as well, but we need to try to reach young people, to your point, before they become users. And so there's where we got to figure out a way to capture them quickly. And I think Oregon is doing a pretty good job of trying to use young folks to help them approach that cohort.
Well, coming from a state that doesn't have the legalization of recreational marijuana, I think that's an example of where some of the issues may be. I know there's a lot of people that believe that's a good thing to do. I personally am not one of them. Quickly, on the suicide prevention line, you've asked for a lot more money here. We've provided a fourfold increase in fiscal year 2023. You're requesting $100 million more for 2025. I'm wondering, can you give me a breakdown? You might not have that right now, but how is this breaking out to, is it going out the door to state and local crisis centers versus a contractor that's administering the system? I'd just like some more details on this request, given the sensitive nature of the program and the critical work they do.
Certainly, and we can follow up with your staff to give you more of the details, because those are out there. Most of the money helps sustain the state operations, the call centers that already existed. We essentially have buoyed them because we established backup call centers because a lot of the states didn't have the capacity to deal with all the calls that might come in. We didn't want people waiting on the phone
No.
with a busy signal.
Yeah.
So we stood up all the backup call centers. We also made specialty lines. So, for example, if you're a veteran, there's a line that's
Right.
specific for you. Those are the things that the federal dollars have really helped boost. We also helped create the text and chat feature so that if you didn't want a phone
Is that
call,
online now, the text and chat feature?
yeah, absolutely it is.
Okay.
Absolutely. It's available now for hearing impaired. It's available in some places, Spanish language. We're trying to make sure no one feels like they should not call. And now you hear that we're going to finally get to the point where we can make the 988 call work so that wherever you are, whatever your area code is, you're going to get a professional where you happen to be, not based on your area code. It's working. The $600 million that is in the president's budget for 988 is absolutely going to save lives. We know that in the first 18 months of launching National 988, 1.5 million people reached out to us and said, help. We were able to answer.
Thank you.
Thank you. Senator Kennedy.
Thank you, Madam Chair. Thank you, Mr. Secretary, for being here. Mr. Secretary, if the mother is healthy and the baby is healthy, do you really support abortion of the baby up to the moment of birth?
Senator, let me make sure, to the moment of birth, you're saying after gestation, the 40 weeks?
You know what I'm saying, Mr. Secretary.
Well,
let's suppose it's the day before the due date, and the baby is fully formed, and the baby's healthy, and the mother is healthy. Do you support aborting the right to abort the baby then?
I've heard no one say that. I think everyone has said, those who support reproductive rights have said,
you
support
said
Roe versus Wade.
You said it in 2020 in a press release. This is what you said. You said, quote, no government, state or federal, has the right to make decisions for a woman about her body or her health care, end quote. Your words, not mine.
Good words.
So let me ask you again. Up to the moment of birth, if the mother's healthy and the baby's healthy, do you believe that there should be the right to abort that baby up to the moment of birth?
Again, I'll give you the answer. I have always supported Roe v. Wade, which does not do what you've just said. And I know of no one who is proposing or advocating what you've just announced. And I would hope that what you would recognize is that that should not stop a woman from having the right to decide for herself with the consultation of her physician what she should do.
Would you support making it illegal to abort a baby if the mother's healthy and the baby is healthy on the day before that baby is scheduled to be born?
I certainly would support the reestablishment of Roe versus Wade.
Okay. So you think that there are restrictions that the state, federal or state, as the case may be, can place on abortion?
Senator, if you talk to any woman, she'll tell you that she uses common sense in making her decisions.
Do you think that the state or the federal government in the third trimester of a pregnancy has the right to impose limitations, moral and legal right to impose limitations on an abortion? I think that's a yes or no.
I would certainly say that Roe v. Wade answered those questions. We defend and support Roe versus Wade.
Roe v. Wade has been overturned. I want your answer. Do you support restrictions by the federal or the state government on the right to an abortion in the third trimester?
And my answer is clear that if we establish Roe versus Wade, we get back to a system that gives women protection.
Do you support restrictions to the right to an abortion in the third trimester? Why are you dodging the question?
I'm not. I'm just saying. I'm
Sure
telling
you
you
are.
where I am. I am.
Now, tell me, do you support restrictions in the third trimester?
I have
if
personally.
the mother's healthy and the baby's healthy.
Yeah, and Senator, let me try to make sure I answer this. Personally, as you mentioned, I've been quoted on a number of occasions before I became secretary. I support a woman's right to make a decision about her body.
But do you support restrictions in the third trimester? I just asked, why are you embarrassed to answer?
Because I believe in Roe versus Wade, and I think everyone recognizes
You
that
support
that
Roe v.
law.
Wade?
I do.
Roe v. Wade allowed for restrictions in the third trimester.
Then you have your answer.
Do you support restrictions in the third trimester?
If Roe versus Wade is as you described, then
Why are you scared to answer the question?
I'm not afraid to answer. I'm
Are you
asking
worried
the
you're
question.
going to get in trouble with people, with your colleagues
No,
who
not at
support
all.
abortion up to the moment of birth?
Not at all.
Then why won't you answer the question?
Because, Senator, I think I've given you the answer that makes the most sense. Roe versus Wade worked for some 50
Do you
years.
support restrictions in the third trimester on the right to abortion? It's real simple. You're the secretary of a department of the United States of America.
Yeah.
Do you support them or do you oppose them?
My answer is pretty simple. We will
It wasn't
defend
simple.
Roe
You
versus
don't want to
Wade.
answer it, do you?
I've answered
You
the
know why
question.
you don't want to answer? Because you and your colleagues believe that a child has no rights, even a fully developed child. You know that?
You can say that.
And I know
I know
that.
where I am. I will continue
Okay,
to
let me
defend
ask
a
you
woman's
for a
right.
final time. I think this is number 5.
It's not gonna make any difference, but go ahead.
Yeah, well, if you want to choose to not answer it, that's up to you.
I'm not denying anything.
Let me phrase it another way. What restrictions do you support in the third trimester to the right to an abortion? Tell me what restrictions.
If you read the Roe versus Wade decision, it'll answer your question.
Why don't you just answer it for me?
I did. Roe versus Wade
What
established the
restrictions
protection.
do you support on the right to an abortion in the third trimester? You
Roe versus
personally.
Wade. Roe versus Wade.
Okay. Roe versus Wade doesn't say what restrictions. Roe versus Wade just says the state and the federal government have the right to impose restrictions. I'm asking you, what restrictions you support? For example, if the mother and the baby are healthy, and we're a week before birth, and the parents change their mind and say, we don't want a boy, we want a girl, abort the baby who happens to be a girl, would you support that right?
I know no one who would go as far as what you're indicating,
Well, then wouldn't you say you would oppose it?
because I'm telling you where I stand.
No,
And I
you're
have
not.
been very
You're
clear on
dodging
that for a
and
long
bobbing
time.
and weaving and flip-flopping like a
Let me
mad
stand as still as
catfish.
you'd like. Senator, I won't move, and
Let me
I'll just
ask
move
you
my
again.
lips.
If a week before birth, baby healthy, mother healthy, would you support the right to an abortion because the parents dislike the gender of the baby? Yes or no?
Yeah, as I said, a woman should have the right
But you
to make the
haven't said,
decisions
Mr.
about her body.
Secretary, you won't answer my question. Would you support that?
As I said, I'm going to do everything I can to support a woman's right to make the
Would you
decisions about
support
her
what I
body.
just described? You're not going to answer me, are you? I don't understand why you're scared to answer me.
I'm not afraid to answer your question. I've answered it over and
You're
over.
scared
Thank you,
to
Senator
death to
Kennedy.
answer me. I just find that appalling. You're the secretary of the department.
Thank you, Senator Kennedy.
Can we have a second round, Madam Chair?
I am just going to start a second round right now.
I need some answers now. If I just had answers.
You just hang in here. We're going to start a second round of questioning. We will certainly accommodate any senators who have not yet had their first round who appear. As we know, we have several competing subcommittee hearings at this juncture. Secretary Becerra, I want to also address the 988 implementation. I was proud to be the co-sponsor of the 988 legislation along with former Senator Cory Gardner, and believe that it has been a remarkable service. You know, we always had a suicide prevention hotline, but nobody remembered the 10-digit number, especially at a time of crisis. And when we launched the 988 number, it has literally been a lifeline for so many. I want to ask you specifically about a pilot program that has been underway regarding LGBTQ youth. You mentioned already when you call, there's a screening for service members. If you're a veteran of our military service, you can get routed to appropriate and knowledgeable services. Last year was a record-breaking year for legislative efforts around the country that target LGBTQ individuals, including the ability to receive health care, inclusion in education, even access to public restrooms. It should not, therefore, be a shock that lesbian, gay, bisexual, and transgender youth are more likely to experience anxiety, depression, and thoughts of suicide than their peers. In fact, LGBTQ young people are more than 4 times more likely to attempt suicide than their peers. We're seeing that these attacks do not live in a vacuum and that they have real-world consequences. I have been glad to work with you and the department in creating and now expanding specialized services within the larger 988 Crisis and Suicide Prevention Lifeline to provide response to LGBTQ youth in crisis. We know that there's a need there. In February alone, almost 40,000 contacts were answered by the LGBTQ sub-network of 988. Can you expand on how these specialized crisis services for LGBTQ youth and the pilot has helped support this population?
Madam Chair, absolutely, because I think you're going to the heart of what makes 988 so valuable, and that is that you have individuals who are challenged, who are at a moment of crisis, who turn to someone and actually trust, will extend confidence in someone through a phone call, through a chat, and that's a tremendous thing. And so to begin this pilot back in September of 2022, see it working, expand it to some 7 different call centers, and see more than 40,000 calls come in specifically from the LGBTQ community means that they're responding. We want to continue that because we want anyone who's facing crisis to feel like they can have the confidence to make the call, have their call be personal and private, and also get the help they need.
No, thank you. I was just singing the praises of the program, but still, there are many people who are unaware of this crisis service. And I understand HHS is planning a public awareness campaign to spread the word on 988. Will the proposed increase for 988 included in the budget request support the anticipated increase in call volume as a result of the awareness campaign that you're conducting?
We're hoping to address it. We're hoping states will further step up to the plate to help us because at the end of the day, it's their call centers that are the front line. So we need states to continue to grow their capacity because we can only depend on the generosity of Congress to help sustain that national component. What we don't want is to have gaps. We want you to be able to call from whatever part of the country you're in. So we continue to partner with states and tell them, please, make commitments in your own budget to sustain your operations. Some states have actually done that. They've got a permanent flow of dollars. Most states don't.
Thank you. Senator Manchin.
Thank you, Madam Chairman. Secretary, I was pleased to see the department's finalized the rule implementing the Jessica Grubbs Legacy Act we worked on for so long. The law reduces barriers for treating persons with substance abuse disorder by aligning the privacy laws governing their records with HIPAA, the law which governs all other health privacy records. This has allowed for medical professionals to access vital information they need to properly coordinate the care. In 2018, Congress passed a separate law in honor of Jessie Grubbs' life, just called Jessie's Law. This requires HHS to develop best practices standards for hospitals and doctors to display a patient's history of opioid disorder when the patient provides that information. With the implementation of the Legacy Act, it's now time to fully implement Jessie's Law. So the department has finalized a rule on confidentiality of substance use disorder patient records. When will it be releasing best practices for displaying opioid use disorder in patient records?
Senator, first, thank you for the work you've done because I don't think people recognize that in many cases because of this I don't want to call it an excuse, because of the difficulties with privacy laws, HIPAA privacy laws. A lot of essential information about a patient wasn't getting to the providers, and they were making the wrong decisions, especially when it related to drug addiction. And so the work that you and your colleagues have done has really helped.
Well, Senator Capito and I worked on, but we know the family very well. It was so horrifying. This young lady had problems, and something stemmed from when she was in college, but then she was trying to get herself clean. She started running and being competitive.
Yep.
And she and her parents, who an attorney and her mother's a educator, both went with her to the hospital and says, please identify and mark my record showing it, and they forgot to do it.
Yep. And so what we're doing is we're trying to tackle that HIPAA privacy hurdle so that it doesn't become the reason the information isn't fully there. But you can understand how important it is to maintain privacy.
Oh, no, we know that. But now that we've done everything, we've gone through every hoop possible.
Yep.
When will you all be doing? When can we expect it to finally be implemented?
We are now working with providers. We've developed a training module so that they understand how this can work, how they can be consistent with privacy laws, yet still include the information. So a lot of it's going to be, and we can use your help, because we need providers to start understanding what the new rules are. They're going to say to you, oh, no, we can't do that because of HIPAA privacy. We want them to understand, oh, no.
Well, I think
Jesse's
the
law
law is
makes it
very
difficult.
clear. Basically, it says that the patient himself and the guardians have to have permission and give you permission to do it.
Yeah.
So we thought we crossed every hurdle, crossed every T and dotted every I.
Yep.
It's just time to implement it. So I would implore you to
We're doing it.
Get your staff moving on this one here. We've waited a long time for it.
And Senator, I'm just pointing out, we need the help of the providers to make sure that they're getting their personnel to understand the new rules.
Okay.
Yeah,
Well, I think the quicker you put them out, the quicker they'll understand them.
absolutely.
The Health Resources and Service Administration administers grants and programs that are critical to rural health centers and clinics and hospitals. Your budget requests a $2 billion increase to this agency to carry out these programs. However, many areas of West Virginia remain unable to access these resources. West Virginia is the only state that lies completely within the Appalachian Mountain region. The United States Department of Agricultural, Economic Research Services recognize the unique topography. We're the most rugged mountainous state, east of the Mississippi. And a recent report on what we call rugged terrain. That's all been identified and how we've been classified. The report found that almost 81% of West Virginians live in a rugged area. That's compared to just 11.7% of the entire United States population. The fiscal year 2024 bill included language for HRSA to review this report to update their rural definition to better capture the uniqueness of Appalachia. Can you provide an update on this review and a timeline for when we're going to see some results so they can qualify for the needed funds they need for rural health care?
So we're not waiting. As you know, Senator, we are moving forward with a new classification, this new classification for hospitals that don't meet the critical access care definition, so that a lot of those facilities that are teetering don't go under, so they can get some additional funding. I was mentioning to Senator Capito some of the work we're doing to make further investments in behavioral health, especially in substance use. But we are absolutely prepared to work with you as you all give us some guidance about how to get into these communities that are very rural to make sure we're being as constructive as possible. We will work with the states as much as we can because they understand better what their state needs in terms of the rural health facilities. But we're trying to make sure that these new changes that you helped us put forward will help some of the states that have large rural communities address the concerns of individuals a lot faster.
Well, sir, I thank you for your service. I just want to say again on Jesse's law, that has been a long time in coming, okay? And the families are just they're hanging on needles and pins, just waiting for it to be completed. They want to save lives, and they don't want anyone to go through what they've gone through. And on the rural classification, if you want to know why that divide is becoming bigger and bigger, rural areas have been left behind. The money has not gone appropriately for the challenges they have, and that's so important.
Yeah.
Thank you, sir.
Thank you.
Senator Hyde-Smith.
Thank you, Madam Chairman. Good to see you, Mr. Secretary. Thank you for being here. In 2003, Congress established the Rural Community Hospital Demonstration Program to test an alternative payment model for rural hospitals that were facing certain financial constraints with the Medicare's Inpatient Prospective Patient Program, the IPPS. And Congress has extended the program several times, most recently in the Consolidated Appropriations Act of 2021. but Mississippi ranks among the states with the highest rate of hospital at-risk closings. This demonstration program could serve as a means to keep their rural hospital doors open to serve their communities in need of high-quality health care. However, CMS has not solicited applications since 2017, despite, as I understand it, there being a handful of open spots in the program. Do you believe this program has been helpful to rural hospitals facing closure, and we should extend the program when the time comes?
Senator, thank you for the question. The rural emergency hospital designation extended a lifeline to some of these facilities. It is absolutely essential that we give hospitals that are willing to stay open a chance to survive if the older version definition of how they could get reimbursed isn't working for them. So we look forward to working with you, because we've got to figure out a way to keep some of these facilities open and operating.
Do you know about how many spots are currently open right now in the program?
I don't have that with me, but I can make sure my team follows up with you.
No problem. And can you commit to working with me to solicit applications for the program and find ways to help us keep these hospitals open?
Absolutely.
I talked to administrators this morning that have been in my office, and we are constantly battling this in Mississippi. You know, we're just putting out one fire after the other. Mississippi has consistently seen some of the poorest maternal health outcomes in the nation, made worse by high rates of chronic disease and limited access to specialty care for many mothers. And we've also led the nation in infant mortality, something that we're not proud of at all and very concerned about, but it's driven largely by a very high preterm birth rate stemming from lack of prenatal care. Access to maternity care in rural areas is a major challenge, and we are seeing a rapid expansion of OB deserts, that we refer to them as, across Mississippi. In some areas of my state, women are having to drive more than an hour for any kind of obstetric care. How can we work with you to improve outcomes for our mothers and babies in Mississippi?
Senator, because everything you've said I agree with regard to maternal health, and especially how it's impacting our Black and Native American communities. The most important thing is early access. And as you've mentioned, sometimes, especially because a state like Mississippi has a lot of rural communities, it's tough to have access. And so that's why it is so important to not allow any existing health facility to go under in rural America, because then the access becomes even more difficult. Telemedicine, telehealth is going to be very important for communities, families in rural America, because it means they can have access without having to do the physical travel. We'll continue to support that so long as Congress gives us the flexibilities to offer telehealth flexibilities. But the most important thing is access. And I will simply say here, many of the women who are having bad outcomes could have qualified for earlier care had they been eligible for Medicaid. And I think if we expand Medicaid in some of the states that haven't yet done it, about 1.5 million more Americans, many of them women who want to deliver a baby, would have access to early care and not wait until it's a difficult circumstance in the delivery.
Yeah, well, I appreciate your concern and your willingness to help toward this, because it truly is crucial. Mississippi's a large state. We don't have many people, but we're a large state.
Yes.
And we're scattered. And it is truly a hardship on so many mothers to actually get to that care. We have a lot of babies born in cars, sad to say. My time is out. Thank you.
Chair Murray.
Well, thank you very much, Chair Baldwin. Secretary Becerra, good to see you. I appreciate you joining us today. HHS really is on the front lines of some of the most challenging issues that our families are facing. Opioids, mental health, childcare, so much more. It is crucial that we maintain strong investments in life-saving biomedical research, building a strong healthcare workforce and public health system, getting families affordable care close to home, and a lot more. Not to mention the constant attacks on reproductive care. Women in 21 states are now living under abortion bans, and Arizona is under a ban that dates back to before women even had the right to vote. Despite strong support for abortion access around the country, anti-abortion extremists are continuing to attack not only abortion care, but IVF and birth control. Everyone, I believe, deserves the freedom to control their own bodies, their own lives, and their own future, free from interference from politicians, which is why I strongly support President Biden's decision to once again remove Hyde from this year's budget. I look forward to continuing to work with you to protect reproductive health care every way we can in all 50 states. And I'm glad we have the opportunity today to talk about how we can provide the resources necessary to meet all the health care challenges before us and support families in my state and across the country. Programs like Child Care and Development Block Grant and Head Start are a lifeline for working parents who need affordable, high-quality child care and early learning opportunities for their kids. They're an investment not just for our families, but in our workforce and in our economy. So I'm really glad that Senator Baldwin and I were able to send an increase of $1 billion to the President's desk to invest in child care and early learning for FY24. Since 2015, I and many others have increased funding for these programs by more than 250%. But it is, as you know, a drop in the bucket when looking at the child care crisis that exists in this country. We need to protect and strengthen the investments we've made to make sure families can find and afford child care however possible. That means more annual funding, extending stabilization dollars, and hopefully passing my Child Care for Working Families Act. Can you tell us today about the current state of the child care sector and why investments in programs like CDBG are critical now more than ever?
Senator, thank you. And again, thank you for championing child care writ large and your success in getting additional funds for so many families desperately in need. Today, getting child care is like having your infant go to college. The cost of child care is essentially tuition in a major university. It makes it very difficult for parents, especially parents who have more than one child, to really sustain that. We also know that the quality of care can sometimes be questionable because the pay for some of these workers is so low. You can sometimes make more money flipping burgers than caring for children. We need to change that as well. The President's budget, thanks to the investments that many of you have made possible, will continue to move an effort. The President's proposal would make it possible for some families to qualify to have child care for $10 a day, which would ultimately save them each, those families, about $7,200 in a year in the cost of their child care when you total it up. That would be a proposal that would help so many of the families, some 16 million families would qualify for that support. And so it's so important to move forward, as you said, to continue to make the investments in child care.
Thank you. I really appreciate that. We'll continue to focus on that. Mr. Secretary, this week is Black Maternal Health Week. It's an important time to talk about the devastating maternal mortality crisis here in the United States. The U.S. is now one of the most dangerous places in the world to give birth, and that really is astounding to me, despite most maternal deaths being preventable. It is clear our systems are failing mothers, especially Black, Hispanic, and Native mothers who experience the highest rate of maternal mortality. And extreme state abortion bans passed since the Dobbs decision have further eroded the access to maternal health because we don't have as many providers for maternal health care across our country. We were able to secure a $21 million increase for the Improving Maternal Health Initiative across HRSA, CDC, and NIH in our FY24 bill, and building on increases from 23, and I hope to continue that progress in this budget. Can you talk to us about what HHS is doing now to address this issue and about the additional investments in maternal health that you're actually proposing for next year?
And again, because of the efforts of you and others, we've been able to continue to increase the funding of maternal health. This budget, 2025 budget by the President, provides close to $400 million for maternal mortality and morbidity. to address that, because as you mentioned, in too many cases, a black woman is 2 or 3 times more likely to die at childbirth than a white woman. I think I misspoke and said $8 billion. It's actually $2 million in this federal budget by the president is dedicated to maternal health. We are now, as I mentioned earlier before you got here, Senator, making available care for a woman who qualifies for Medicaid and for her baby, rather than just for 60 days, she now qualifies for 365 days of care, and so does her baby. We're doing a lot. Doulas are being made available to families. We're trying to do what we can up front before the delivery, so the woman gets good care before delivery, gets good care during delivery, and good care after delivery.
Okay, very good. And finally, on youth homelessness prevention, I am laser focused on making sure the federal government is doing everything we can to support young people who are experiencing homelessness and doing more to prevent it. I was very proud to champion new funding in our 24 bill for a demonstration program that will provide grants to state, local, and tribal governments and local organizations to help prevent youth homelessness. What is HHS doing to address and prevent youth homelessness?
Senator, thanks for that work that you're doing. We are working with states. I'm the chair of our Interagency Council on Homelessness, working with HUD and other agencies to make sure that we're tackling homelessness with the support of the local governments who actually have the day-to-day responsibility for it. I will tell you this, we are focused on getting families and children first and foremost off the streets. We're trying to make sure foster kids don't fall into homelessness once they age out of the foster care system. And so we're doing what we can. And by the way, we're also focusing on LGBTQ young people, because we know so many of them end up becoming homeless. And if we get to them early, we can keep them with a family, we can keep them healthy.
Thank you. Thank you very much. Thank you, Madam Chairman.
Next, for a second round, we have Senator Capito.
Thank you. Thank you again, Mr. Secretary. We authorized ARPA-H it was funded at $1.5 billion, and you're requesting flat funding for ARPA-H. For those who don't know what that is, it is intended to fund high-risk, high-reward research to find biomedical and health breakthroughs. It's fashioned after DARPA, which is done in the defense arena. And biomedical research has long enjoyed bipartisan support, of which mine is obviously part of that support. I have heard some concerns about either repetitive or deflecting or competitive, maybe, research that could be that is conducted at NIH as opposed to ARPA-H. So ARPA-H reports to you, and NIH is a separate entity. And I would like to know, can you tell me how you plan to make sure that the research activities of ARPA-H and NIH remain distinct? And I mean, I don't think they should be siloed, because one can feed to the other, but to avoid that duplication.
Senator, so just to be sure we're clear, both NIH and ARPA-H report to me, but ARPA-H, which is very similar in its research mission, some said should have been housed within NIH. What we did was we kept it separate, because it's supposed to be a much more nimble operation. The difference, basic research is done at NIH. It may take 10 to 15 years before we see some novel discovery come out of the NIH research. ARPA-H says in 2 years, no more than perhaps 3 years, you're on the ground with this novel approach. And so ARPA-H was, as you mentioned with DARPA, with the Department of Defense, to help us get those innovators who are having difficulty finding enough money because it's a small idea, actually get them off the ground. And so this is where that cutting-edge research will quickly get moving. And so ARPA-H has actually had some great successes. And as I mentioned to you in our conversation, I'd love to make sure that if you'd like, we let you know some of the projects that are underway at ARPA-H.
Yeah, so I understand your longest project so far is 9 months old. I mean, that's because this is a new program.
Correct.
You have the ability to withdraw funding at any, but I don't know how many projects you have going, 9 to 10 maybe going right now. You have the ability to withdraw funding if it looks like these things are, that's some of the hardest things to do, as we know.
Yes.
We serve together. Have you withdrawn any funding from any of your projects that are moving so far? Is it too early to tell?
We're only 9 months in, and so usually 2 to 3 years, but you're right. These program managers are hired with the understanding 2 or 3 years, and that's it.
And so do you have a firm and affirmative oversight plan to make sure that you're redirecting funds if somebody's got an idea that's not going to work, let's move on, and
Yeah,
you have that oversight plan already in place?
Yeah, Dr. Wegerson, who, by the way, came from DARPA, Dr. Wegerson understands that completely. It's in the design of the proposals. Everyone understands this is not going to be something that's living for a decade. It's either you hit it, you have success, or we're moving on.
Okay. I want to ask you about your return to work process. COVID's over. It's been over for over a year now. The White House Chief of Staff, Jeff Zients, and I excuse him if I pronounce his name incorrectly, encouraged agencies through an order in May 11, 2023, to bring back in-person work policies. What is your in-person work requirement?
We are complying with the OMB guidance that was put out there.
Well, what is that? I don't know what that
It
is.
essentially says make sure that your work plans with all of your employees have a mix. So some are full-time, some are have some telework ability. And so it's having the mix, and what you're traditionally trying to do is have at least half of your workforce in at all times.
Okay, so approximately what percentage would you say is back in the office 5 days a week?
As I said, we're complying with the OMB guidance.
Well, I know.
So that
you said
means
but-
we're essentially there, but we're 90,000. We have people throughout the country. We have a mix. Unlike other agencies, we have folks who are medical
Have you
providers.
negotiated any contracts or with the federal unions that say you have to be in 2 days every 2 weeks and a day is 6 hours?
Yeah, we've negotiated contracts with the unions to make sure that we're complying with the OMB guidance.
Well, I mean, are some of those like that?
Yeah,
Because
they
I
would-
know we're finding that in other agencies.
Yeah, for example, telework has been around for a long time, and so we may have made adjustments to the telework plans that we have, but what we have to do is because they're under an employee collective bargaining agreement, we have to
Okay,
discuss that
so
with you.
can we have your collective bargaining agreements? I mean, I'm sure they're public, so we could see what you've negotiated in certain areas. Because quite honestly, 4 days a week, a 2-week period, 6 hours is a day, most of America would begin laughing at that.
Right, and that's not something that you have for the 90,000 people in the workforce. But let me see what I can do as far as providing you some of that information.
All right. And then well, I think my time's up, so I'll let these guys go ahead. Thank you.
Thank you.
Senator Kennedy?
Mr. Secretary, how many employees does the Department of Health and Human Services have?
Roughly 90,000, Senator.
And your testimony is that half are back in the office full-time and half aren't?
That the OMB guidance essentially calls for a process where we
I
can have
understand the
physically.
OMB guidance.
Yeah.
Is it your testimony that half are back of those 90,000 are back in the office full-time and half aren't?
My testimony is that we are in compliance with the OMB guidance on how we handle the workforce.
Is it your testimony that half of the 90,000 are back in the office full-time and half aren't?
Again, my testimony is that we are complying with the OMB guidance. Like, we can make sure you know what the guidance is, so
I do
you know what we're
the
complying
guidance
with.
is. I'm just trying to understand how you've implemented it. What percentage of your employees are back in the office full-time?
I could try to get that information back to
You
you
don't
because
know?
we have a mix. I came to talk about the budget, but I can try to
You
get
don't
back
have
to
any
you.
idea how many of your 90,000 people are back in the office full-time?
I can tell you the types of mix of employment that we have.
Yeah, but that's what I'm asking. You got 90,000 employees.
That's right.
How many are back in the office full-time? What percentage?
And as
You
I said,
don't know?
this is a budget hearing. I came to talk about the budget.
Yeah,
if
but you don't know. You don't know how many of your people are back in the office full-time.
I can get back to you, Senator.
I find
I
that
could get you as
astounding.
best I can a response to that particular question, but I came here to talk about the
Why
president's budget.
is Medicare Advantage so popular?
I'm sorry?
Why is Medicare Advantage so popular?
Why is Medicare Advantage so popular? You'll have to help me with, what do you mean by
You
that?
don't know what Medicare Advantage is?
I absolutely know what Medicare Advantage is.
Yeah,
When
why
you
is
say
it so
popular, is there some survey that you're talking about, or what?
Yeah, I deal in numbers.
Okay.
About half of our seniors who qualify for Medicare choose Medicare Advantage, don't they?
That's actually more than half.
Okay. And why is that? That makes it popular, right?
Medicare Advantage today, this is the first year that we've seen more individuals select plans in the Medicare Advantage
Why is it
managed
so
care program.
popular?
Again, when you say popular, I've heard many Medicare beneficiaries who are complaining about being stuck in a Medicare Advantage
Well,
plan.
is it because the average person, average senior on Medicare Advantage pays $2,400 less in premiums on Medicare Advantage as opposed to traditional Medicare, plus gets more services like dental and vision in many respects? Could that have something to do with it, you think?
I'm assuming that you've seen some polling or surveys that give you some of those answers. I've heard many, many things,
No,
both
I've
good and
seen,
bad about
I've
Medicare
seen the
Advantage.
facts. Are you telling me that people on Medicare Advantage don't save money in premiums and copays over traditional Medicare?
I have
Is
no
that your
doubt that some
testimony?
do, but I wouldn't have no doubt that some pay more.
I'm talking about the average.
Again, I don't know what numbers you're referring to, but I'm
looking
more than willing to
at the
discuss
numbers
those
that
with
your
you.
department puts out.
Okay, then what are those numbers,
The
Senator?
numbers say that the average person on
I'm asking if
Medicare
you could show me the
Advantage
numbers.
pays $2,400 less in premiums and copays and gets extra benefits. Is that right?
My understanding is they're also restricted in the doctors they have access to, the hospitals they have access to.
You're trying to destroy Medicare Advantage, aren't you?
We've actually provided an increase in funding for Medicare Advantage.
No, you haven't.
Sure we have.
You cut funding in 2023 by 1.1%.
That's absolutely incorrect.
And you, next year, you're proposing a 0.16% cut. And in fact, the Medicare.
That's absolutely incorrect.
That's not incorrect.
That's absolutely incorrect.
And in fact, the Medicare trustees.
Senator, saying it doesn't make
The
it true.
Medicare trustees said that you've lost your mind. My words, not theirs.
Senator, saying something doesn't make it true. The dollar amount that we're giving to
You
health
have,
insurance
you
companies
have
under
cut,
Medicare Advantage
are you telling
has
me today that
increased.
you have not cut payments to insurers in Medicare Advantage last year by 1.1%?
We are giving Medicare
denying
Advantage. Health insurance
Are you
companies
denying that?
under Medicare Advantage are receiving more money this year than they got last year from
You
Medicare.
cut them by 1.1%.
That's not a cut, Senator.
And you're proposing another 0.1% cut. In fact, I mean, you and President Biden say you will not touch a hair on the head of Medicare, but you're trying to destroy Medicare Advantage.
Actually,
I mean, look-
the president's budget extends the life of Medicare
look at
beyond
the-
your and my lifetime.
Look at the numbers. In 2023, under your watch, Medicare Advantage patients saw on average a 12% increase in deductible and a 5%
The
increase
insurance
in
companies did that,
premiums.
not us, Senator.
And Florida and Utah and Wyoming saw their premiums go up 50%.
Okay, Senator, blame the insurance companies, not us.
Because you cut the payments to
Senator,
the
we did
insurance
not cut.
companies to drive them to traditional Medicare where you can control them better. Isn't that the case?
The fiction you're propounding doesn't resolve the issue that we have every year so far under this administration increased the funding for health insurance companies who offer these managed care Medicare Advantage plans.
Thank you, Senator Kennedy. Now I'll recognize Senator Hyde-Smith.
Thank you, Madam Chair, for your indulgence.
Mr. Secretary, Mississippi has one of the highest rates of cardiovascular disease and deaths from this disease, and the frequency of the disease continues to increase. It's been concerning for a very long time. It's important that Americans receive cholesterol screenings and appropriate treatments to manage this cardiovascular disease to prevent further complications that could lead to sicker outcomes or even death. The fiscal year 2023 Labor HHS report included language requesting a report which was supposed to be completed in the summer of 2023 on cardiovascular disease and the implications associated with postponing, delaying, or being provided sub-treatments. This remains a critical issue in Mississippi and a critical issue across the United States. I was very disappointed that the department and nearly is nearly a year late in providing that information to this committee as it was instructed to do. Can you tell me the status of this report, and how do you explain why the department did not comply with the deadline?
Senator, I'm going to confess to you, I don't have that information in front of me, and I apologize. So how about we do this? Let me huddle with the team, and I'll do it as quickly as you like, and we can get back to you on that particular answer. I don't want to give you misinformation, but I wish I could give you something, and I don't know if I have any of that in my notes. So rather than try to wing it, let me get back to you on that, because it's an important question.
But you have no idea why it was late or that it was even late.
And I'm sorry, I can't, I don't know. I can't tell you that I remember my team saying to me, we're going to be late. And so rather than give you, again, rather than try to dance, let me get back to you as quickly as possible. Madam Chair, if the senator would like, we could put my response on the record.
Without
We would
objection.
like a response to that pretty quickly. And as we look at what may be the most consequential year for telehealth policy to date, we cannot overstate the urgency for Congress and CMS to act on Medicare legislative and regulatory telehealth flexibilities. Our nation's healthcare systems and providers need clarity. We need stability to implement and maintain the operational and clinical practices needed to ensure seamless quality care for millions of Medicare beneficiaries nationwide. I strongly encourage CMS to work alongside Congress by continuing to share relevant telehealth data with members of Congress and staff, as well as continuing to engage with stakeholders through public calls on pertinent healthcare issues. How actively will CMS engage with Congress this year on telehealth policies?
Senator, will we camped outside your door if you like, because this one is very important to us. As we discussed in our previous Q&A, telehealth is indispensable, especially in rural communities. It avoids the need for transportation. It makes it possible to have immediate access to a professional healthcare provider, and we don't want to lose that. And so we are at your door, ready to provide technical assistance as you all make decisions on what kind of flexibilities to continue to give us in working with the states.
And as you know, many of those flexibilities that allow Medicare providers to offer telehealth expire at the end of this year.
Yes.
And Congress plans to address these policies, but may not finalize updates until the close of the end of the year. Will CMS be able to create a regulatory pathway to allow for immediate and seamless updates to policies when the law is updated?
Senator, I don't think you're going to like the answer here, because regulatory work, as you know, takes more than just months to implement and actually put on the ground and operate. We are absolutely counting on the Congress before the end of this calendar year to come up with some telehealth solutions, because we won't have the kinds of flexibilities that you or I would want to see if we get past December 2024 without Congress acting to extend those flexibilities. We'll do whatever we can at the regulatory level, but more importantly at the executive level where we have any discretion. But as you know, the reason you all had to pass these extensions on flexibilities was because we didn't have a lot of executive discretion on what to do.
Thank you, my time.
All right. Just to give you a quick status update, we're hearing that there are at least 2 other members who are desperately trying to get into this hearing to ask you questions. I will entertain a 3rd round.
Lucky me.
Lucky you. And if they do not appear before the end of our 3rd round, we will let you go. So I want to focus for a moment on the Centers for Medicare and Medicaid Services, or CMS. This agency provides services for millions of Americans through Medicare, Medicaid, and CHIP. Wisconsin families and seniors rely on these programs, and I believe that we need to do everything that we can to ensure that they are working effectively to provide the care that our constituents deserve. Funding for program management at CMS was flat for almost a decade. Can you describe the negative impact that not investing in program management activities has on Wisconsin families and seniors and American families and seniors?
Senator, thank you for the question. I know everyone always focuses on what we do on the ground to help families, and that is absolutely what our governments, local, state, federal, have to do, is be there for folks when they need us. The folks who are there when they need us are the folks who often get neglected when it comes time to providing budgetary authority. So we provide money, Congress provide, and I was here for 24 years as a member, so I remember those days. We'd always fund the program, but we would neglect or skimp on providing funding for the personnel. CMS is essentially in that strait. For the last 13 years, its budget actually has gone down. At the same time, its population that it serves, Medicare, Medicaid, CHIP, ACA, Marketplace, has gone up by over 40%. So it's going in totally opposite directions. Every year we're doing more. CMS is negotiating the drug pricing. CMS is helping states address the Medicaid redetermination so people don't lose their coverage. CMS is having to deal with all these determinations about whether Alzheimer's treatments or cancer treatments will get covered under Medicare. CMS is a workhorse, but it's not getting fed. The people that are doing all the work, unfortunately, are stressed. So anything we can do to ensure that we can continue to have good production would help. And by the way, I haven't even mentioned cybersecurity. CMS, when Change Health suffered that cyber attack, CMS, through Medicare and Medicaid, was there to make sure doctors and hospitals still got money, even though all the systems, electronic systems, had gone down. That was CMS.
You mentioned many of the functions that CMS participates in. Can you speak also to nursing home inspections?
Well, it's, I hate to say it publicly, but I think every American who has their loved one, their mom, their grandfather, their disabled brother in a nursing home expects that there's going to be quality care. One of the ways we ensure quality care is to do inspections, to do the surveys, to make sure that these facilities are providing real care to Americans that we love. Unfortunately, the resources that we have received, especially on the administrative side of the budget, don't allow us to do the surveys 100%. We did over 2/3 of the surveys that we needed to of the nursing homes throughout the country. The funding has continued to go down. I fear that we're going to continue to drop in the number of surveys of nursing homes that we're doing, which one of these days is going to result in some nursing home being in the news because some tragedy happens and it's a nursing home that we didn't have an opportunity to inspect. That should not happen. And if we had the resources, and it's a small drop in the bucket of all the money that you all provide CMS, that would help us make sure that nursing homes are safe.
Thank you. Senator Shaheen.
Excuse me. Thank you, Madam Chair and Ranking Member Capito. Secretary Becerra, thank you for being here today and for all of your work on a daily basis. I'm sorry I missed your opening remarks, but I very much appreciate you mentioning insulin and the need to address insulin affordability. And despite the efforts in the last year's legislation, the Inflation Reduction Act, to cap out-of-pocket costs for insulin for Medicare at $35 a person, we still see challenges with affordability for insulin. Can you speak to that and what we're seeing on the private market compared to Medicare now that we've capped the cost?
And Senator, I know despite many of your efforts to include the $35 cap on insulin for everyone in America, the bill ultimately had to get pared down to only provide it to the 66 million Americans who receive Medicare benefits. The president in his budget calls for extending that to everyone in America, not just those on Medicare. And what we're finding is that in some spaces, some of the manufacturers of insulin have said that they would reduce the cost to commercial private insurance plans to $35, but not everyone in America is experiencing the savings that comes from having access to insulin at $35 a month.
Well, thank you. And in fact, then we have companies like Novo Nordisk who said that they were going to reduce the cost for Levemir, and then now they've taken Levemir totally off the market after saying they were going to reduce the cost. So there's some disingenuousness in what we're hearing from some of the providers. And on a similar note, I've heard from constituents about ongoing shortages of insulin, Humalog and Novolog. We heard from Walter Chapman, who's a 70-year-old constituent in Dover, New Hampshire. He visited 3 different pharmacies. He called several others in surrounding towns before he could finally find his insulin in stock. And he wasn't calling small independent pharmacies. He was calling CVS, Walgreens, Walmart with big footprints. So what are we going to do to address these shortages, and how can we make it more transparent so people know what they're getting?
And this is where work is ongoing. We have a proposal that we've submitted to try to have more transparency in the pharmaceutical industry, because it is so difficult to know what's going on behind the curtain. There is no reason why insulin should be in shortage anywhere, because it's so easy to produce and so inexpensive to produce. But that's the game that's played. And that's why the president continues to want to get behind the curtain. That's why it's so indispensable that you gave us the authority by law to negotiate, to drive down the prices of some of the most expensive medicines under Medicare.
And in fact, we have legislation in the Senate, Senator Collins and I do, Senators Warnock and Kennedy, that would cap the cost, out-of-pocket costs for insulin, as well as dealing with availability. I hope that we will see leadership bring it to the floor this year, because I think we have the votes to pass it. On another note, as you know, Title X funding is critical to ensuring family planning providers can keep their doors open in states, particularly states like New Hampshire, where abortion remains legal, but where we have many small providers and we have state legislatures that are preventing those small providers from getting the funding they need. I appreciate Health and Human Services working with family planning providers in New Hampshire, but can you tell us what else you're thinking about in terms of helping keep those folks in business?
So most every time I travel across the country, I will visit a family planning program, because they are indispensable to so many families. They do more. Some people think all they do is provide care to women. They provide care to families, family planning. The president's budget, as you're probably aware, tries to boost funding under Title X, another $100 million, so we get back to where we used to be in some of the funding levels for these programs, to over $350 million. That's going to be important, because families are desperate for the kind of care that helps them have good outcomes in all of their family planning.
Well, that's right, and it's unfortunate that this is an issue that's become all about abortion, because the family planning providers in New Hampshire serve thousands of women. They provide well-check visits, they provide cancer screenings, they provide STD screenings, and without them, we would have so many people who would not be able to get care at all. So you're absolutely right, and I appreciate what the department is doing. Thank you. Thank you, Madam Chair.
Thank you. Senator Britt.
Thank you, Madam Chair. I appreciate it. Mr. Secretary, thank you for being here today. Obviously, we are here to talk about budgets. I've heard a lot of talk about abortion today. And in particular, when I'm looking at your budget, obviously, there was no mention of the Hyde Amendment to be in there. So I want to confirm that you believe taxpayer dollars should go to be able to fund abortions.
Senator, thanks for the question. The president has made it clear he wants to remove the Hyde Amendment from the budget proposals, and that's what he's done.
Okay, so when we're talking about that, Senator Kennedy asked you a question, and you all were talking about, your answer kept being Roe v. Wade, and I want that to be the law of the land. So let's just stipulate that your hypothetical is the truth. And so if Roe v. Wade were the law of the land, and a woman wanted to take the life of her child the day before her child was due, or the day after her child was due, then you support her ability to choose to do that. Is that correct?
Senator, I will say what I said to
Yeah,
Senator
no. I've stipulated Roe v. Wade is law of the land. So there's 7 states in this country and the District of Columbia that allow you to take the life of a child the moment before a child is born. So clearly you support a woman's right to choose to do that.
Senator, the example you gave is fiction as far as
No,
I know.
it's
Can you give me a particular example?
If it actually is fiction, then why not say no,
Okay, if
that's
it's-
out of the realm of possibility,
I see.
that no woman would think to be able to do that? Because the truth is if you say that taxpayer dollars should go to fund abortions, then you're saying that my taxpayer dollars should go to fund something like that. And if that's unthinkable, then why don't you just say it's unthinkable? And in fact, then we can just take it off the table and not allow that to be legal. Because the truth is, when you do that, I'm going to read this to you. In particular, when these abortions occur, the gruesome surgical techniques involve crushing, dismembering, and removal of the fetal body. So they actually deliver the baby breech and then have to put scissors up the baby's neck, open it up, and then suck out the brain so that they're able to get the head through the birth canal. And so then there's also the opportunity to go in and actually put a needle in that child's heart and kill that child. If that child is then delivered alive, do you believe that that child on that table, that we should be able to save that child? Or do you believe that our taxpayer dollars give this woman the right to say, don't save my child? I just think when we're talking about this and you're saying so boldly, no taxpayer dollars go, and you actually won't answer the question when it comes to Roe v. Wade. And I'm saying I'll stipulate that your hypothetical is the case. There are still 7 states in this country and the District of Columbia that allow us to do that. We're one of like 7 nations that allow that to take place on our soil. 2 of the other nations are North Korea and China. And I just believe when we're talking about budgets, I want you to know where I'm coming from and why I believe wholeheartedly with every ounce of me that we have to preserve the Hyde Amendment. And on that note, moving to maternal health. When we look at this, Alabama knows this issue all too well when it comes to maternal mortality and the crisis we have in this country. Nationally, the number of reported pregnancies related to deaths in the United States increased from 7.2 deaths per 100 live births in 1987 to 17.6 deaths per 100,000 live births in 2019. We are moving in the wrong direction. Obviously, with more resources and technology and availability, we should be able to turn this in the opposite direction. The resources made available by HRSA's Title V Maternal and Child Health Services Block Grant are essential to reducing maternal mortality rates and providing better access to quality health care and services. Most of this vital funding goes to states to help them address the priority health needs in their state. Mr. Secretary, with this happening, why does your budget request actually deduce and take funding away from the Title V Maternal and Child Health Services grants that actually go to the states?
Senator, we actually increase funding for maternal health. We have some $2 billion in our budget for maternal health.
But the actual grants, though, went down. The number for the grants went down.
We'd have to take a look at that because we have actually continued to provide support. And for maternal mortality and morbidity programs, we are doing more. We have some $360+ million in this budget to address the maternal mortality and morbidity rate.
Well, I'd like to actually work with you on that because obviously Alabama, this is a significant challenge. We have the highest maternal mortality rate in the nation. My reading of your budget is that that number actually goes down even though your overall budget goes up. So let's have a conversation about that because we need that money in the states. It looks like you have a project-driven basis where a lot of that money is going. These grants help us, particularly in our rural communities, make sure that we can get the care to these women that they need. And so I'd like to, if you will commit to working with me on taking a look at that and making sure that states have the money they need to make an impact.
I commit to follow up with you on that.
Thank you.
Thank you. Should no one else arrive, I'm going to recognize Senator Capito for her last round and then conclude the hearing if another member does appear. Okay, Senator Capito,
Yeah.
and then I will allow both of the, since we have had multiple rounds, I will allow that. So go ahead, Senator Capito.
Yes, Mr. Secretary, I will not have you answer these, but I'm going to put these on your radar, and maybe we can get follow-up in written. First of all, I want to talk about the Alzheimer's disease workforce. We know that this is a challenge, as you've discussed in many other areas. We know that half of our primary care physicians do not feel like they're adequately prepared to care for individuals living with Alzheimer's and other dementia. So joining with Senator Klobuchar, we've introduced the ADAPT Act, which would help it would provide grants to organizations to set up dementia-specific Project ECHO programs that have been successful in a small way, I believe emanating from New Mexico, to educate and support primary care providers in detecting, diagnosing, treating, and caring. So that's an issue of great importance to me, and if we could get a reaction there. And then the other thing, and this is very brief, avian flu. I'm a big believer in preparedness. We weren't ready for COVID as well as we could have been and should have been. We certainly got lessons learned here. Yes. And we've seen where avian flu has been passed from I believe, steer or beef cattle to a human individual. Yeah. I'm just putting that on your radar, so as an area of concern for me. Thank you very much for coming.
Thank you.
Senator Britt.
Thank you so much, Madam Chairman. I really appreciate it. Mr. Secretary, you've said by helping rural hospitals stay open, we are helping residents of rural areas get the care they need close to home. Having access to care nearby is not only more convenient, but it also lends to better health outcomes and boost local economies. I want to say I couldn't agree with you more. I certainly hope that you mean that, and I assume that you would confirm that you do.
Yeah, and any ideas you have, because there are a lot of healthcare facilities in rural America that are on the verge of closing. Yeah. Once they close, it's tough to reopen, so we're more than willing to work with any of you who are interested in that.
That is wonderful, because that's actually the commitment I want from you today. We, as you know, there are a very small number of new rural hospitals that opened in 2020 just before the country shut down, and one of these hospitals is actually located in Alabama. So Thomasville Regional Medical Center was among the unfortunate few who were deemed ineligible for provider relief funds due to the formula's reliance on the figures from 2019, and you're well aware of this, as you know. Yeah. Throughout your tenure, many of my colleagues, Representative Sewell there on the other side, in the other chamber, and on the other side of the aisle, has talked to you about this and has asked for your commitment in budget hearings just like this, and received it, to working with us to find solutions for this group of needy hospitals. These members received a commitment from you and their offices to ensure that these hospitals received proper federal assistance via the Provider Relief Fund. And so my assumption is that you stand by that testimony. And my question would be, what actions did you take to ensure Thomasville Regional Medical Center received adequate provider relief funds?
Thomasville, like many of the facilities that have applied, have to meet the criteria that Congress set forth for us to be able to fund them with the provider relief dollars that were made available. Where we had some flexibilities, some discretion, we took them to try to help some of the facilities that were clearly hurting and in desperate need, especially those that were providing services to folks who are in underserved areas. But our discretion, our flexibility is limited by what Congress set forth as the guidelines for distributing the dollars. Too many facilities, and I suspect Thomasville being one of them, fell within that scope where it became difficult to reach them because of the criteria.
So what do we do? I mean, because there has to be a pathway to help, because just as you mentioned, they are on the verge of closing. And if you look at some of the things that we've seen, they have kind of, the Harvard School of Public Health put out that this congressional district has the lowest life expectancy in the country. And so if we are not going to help hospitals like this that provide people access to care within their communities, your very first statement that I wholeheartedly agree with, then what are we doing? I mean, this is what we're here for. So you're telling me why we can't. Tell me how we can. That's what I want to know.
Yeah, and we can if you all hadn't swept up close to $5 billion that we had in COVID relief dollars, we could have perhaps come to you and ask for you for more flexibility to use some of that money for some of those providers under the Provider Relief Fund. We're out of money in the Provider Relief Fund.
So there was about $7 billion left, right? Is that right?
At this stage, no.
Right, but when that occurred?
Well, left in the sense that it had not yet been obligated, but it was already destined to go to provide different services. It was then swept up by Congress, and now it's no longer available.
So what can we do?
Well, you can always try to re-up the Provider
Well, no,
Relief
I mean,
Fund.
what can you do in your role right now? What can you commit to me to help keep this hospital open? Or what resources are available? What thought process do you have? You obviously sit in the big chair, so don't tell me what you don't have. Tell me what you do have and how we can get that to a path of success.
Well, the problem is if I don't have the resources to make things happen, there's only so much I can tell them we can do, because what they want is money. They're not interested in smiles, they're interested in money. If I don't have money in my pocket, you all swept it up, it makes it tough for me to offer
Do you have
the money.
any money that could work to go towards that at all?
Senator, as you know how the way things work, you tell me where I can spend the money.
Okay, so what would I need to advocate for right here in this budget to help move that forward?
There's two things you can do. Pass legislation that gives us more flexibility in using some of the money you've already given us, which probably would gain some opposition from folks who say, wait a minute, that's already money that we're going to use and you're sending it off to somebody else, so you're going to have to deal with that. But you could do that, give us more flexibility with money we do have, which we don't have flexibility to use, for example, with a program like Thomasville. Or you can re-up a program like the Provider Relief Fund that has some resources so that when Thomasville comes to us, I can say, we now have some resources that we can provide to you.
Will you commit to continuing this conversation with me, the two of us?
Absolutely.
Thank you.
That will end our hearing today. I want to thank my fellow committee members for their thoughtful conversation, and thank you to you, Secretary Becerra. For any senators who wish to ask additional questions, questions for the record will be due on April 23rd at 5 p.m. And the hearing record will also remain open until then for members who wish to submit additional materials for the record. And with that, the subcommittee will stand in recess.